Sorry, I'm just trying to get my slide to shift. There we go. So, what to expect today? So, we'll both be speaking. I'm going to start by talking about identification and the palliative care register. This whole session is about how to identify people in the last year of life and why that's important. So I'm going to talk about national and local priorities. So why, what's the kind of background to why we need to identify patients. A little bit about how we're performing nationally, and then comparing that to how we're performing locally, compared to national, and a little bit compared to our neighbours as well. And then this webinar has come about as part of an end-of-life care QI. So I'm just going to tell you a little bit about the background of that and what's going on. I'm going to talk a little bit about end-of-life care registers and the tools available to support you in developing that. And then I'll hand over to Dr. Berry, who is going to share her experiences within YHP. And then we'll open up the floor to you all to share your experiences that you've been having, any questions that you have, we'll take at that point. And then just a little bit of information about what you might expect next from this project. So, as I say, I'm just going to give you a bit of background in terms of the kind of national policy that's underpinning what we're trying to do. So, we have in palliative care a document called the Ambitions for Palliative and End-of-Life Care, a National Framework for Local Action. It was initially developed in 2015 with an expiry date of 2020, but they've actually built on this document and extended it now to 2026. So this is very much our overarching vision and aims. So this document was developed and published by the National Palliative and End-of-Life Partnership, and that included a multitude of interested organisations such as Age UK, Marie Curie, the Association for Palliative Medicine, and the National Bereavement Alliance, and the Patients Association, and many others. There's a whole list of them. So they all contributed to developing this document. And what they came up with was a vision for how palliative care should be delivered. And I'll read it out because it underpins everything that we're trying to do. So, I can make the last stage of my life as good as possible because everybody works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. And what they came up with is 6 ambitions that, if they're achieved, deliver the vision. So each person is seen as an individual, each person gets fair access to care, maximising comfort and well-being, that care is coordinated, that all staff are prepared to care, and that each community is prepared to help. So alongside that, we also have NHS England's strategy, which is called the Palliative and End-of-Life Care National Delivery Plan. And this is very much informed by the Ambitions document, so it mirrors a lot of that. So it's a 3-year trajectory for palliative and end-of-life care, focusing on improving access, quality and sustainability. And they've come up with some core metrics that will support colleagues in monitoring the impact of the delivery plan. It's obviously quite extensive, so I wanted to just focus in on what's relevant to today's session. So this is the 3 priorities, so sustainability, improving quality and improving sustainability again. If we look at the top of that, we have actions, and then we have what the delivery asks of the ICB are. So relevant to today, we have people are identified as likely to be in the last 12 months of life and are offered PCSP, which is personalised care and support planning. So I suppose that's like advanced care planning plus. So it's planning for the future, but also kind of meeting the care needs and symptom needs now also. So it's a bit of a wider description. So that's the action. And the delivery kind of aim is palliative care registers across primary and secondary care are in place so that we can have timely care planning. So we also have a local strategy and vision. So we have a Black Country Palliative and End-of-Life Care Strategy vision, which is identical to the Ambitions vision. So I won't read that out again. And the goals very much mirror the same kind of priorities. So We want a system-wide approach so that patients in the Black Country, people in the Black Country who are in the last stages of their illness, get the care they need to preserve their dignity and well-being, are supported to be independent for as long as possible, are comfortable and where possible in a place of their choosing, minimising unplanned hospital admissions and living in a community empowered to support them. So just to give you a bit of context for how well we're doing as a country or as a nation, 66% of people say they want to die at home. And the good news is that as a country, we're doing very much better at delivering that. So in 2004, 35% of people were dying at home. So almost half of people that wanted to were dying at home. And in 2022, that had increased to 50%. So we're doing much better. Deaths in hospital were down from 51% in 2015 to 44% in 2021. I know the years on these stats don't match up, but I had to take the stats where they were. We know, so the last two bullet points there are basically to show that unplanned admissions, emergency admissions in the last 3 months and the last year of life are gradually increasing, but only by kind of quite small margins, and that's mirrored locally as well. So if we look locally, how are we doing in Sandwell in the Black Country? So 66% of the British population say they would like to die at home. Locally, 27.7% die at home. So 50% nationally die at home, but locally we're not quite as good as that, so even less than 30%. So we have a bit of work to do there. Black Country in West Birmingham has higher hospital death rate for all causes, and that's even in comparison to the rest of the Midlands. So that is compared to kind of quite local areas. We know that our citizens' use of urgent care starts low, but increases slowly much for the last 2 years of life, and that is not out of context with the rest of the country. That is a trend. So we know that in the last 12 months of life, use of urgent care goes up. And we know that at any one time in the population, 1% are in the last year of life. So if you take a look at a GP practice list, we know that 1% of that practice list are likely to be in their last year of life. And currently, in terms of looking at end-of-life care registers, which are aimed to identify people in the last year of life, we only have 0.12%. Is an average over Sandwell, so obviously some GPs performing it a bit better and some less well in terms of identification, but as an average figure for Sandwell, 0.12% of the practice list is on the end-of-life register. And 80 to 90% of deaths are expected, so it's not that these deaths are not, we can't pick them up, we can. So I won't go through these figures individually, but if we compare Sandwell to the rest of the Black Country, we're performing less well, which I don't want to take this as a negative. It just means we've got some work to do, but we've got lots of opportunity to improve things. And the other good thing is that when we see that other areas are performing differently, that we can try and learn from those areas. What are they doing different there? And that's very much part of the QI that we're doing. So just to look a little bit at the population that we have, we know that the population of Sandwell has high diversity, so we have double the amount of people from Black and ethnic minority backgrounds than nationally, and we know that there's a correlation between ethnicity and deprivation and mortality from preventable illnesses. We need to bear that in mind when we're thinking of providing care for our patients. We have high levels of deprivation in general, so nationally, about 20% of the population is in the most deprived quarter. In Sandwell in the Black Country, that's 30%, so it's much higher. And we know that people living in deprivation have longer periods in ill health from chronic conditions, and these are all factors that lead to high symptom burden, worse mental health, higher social care needs, and lower access to services. So we need to try harder to pick these people up so that they can access services, but also they have more to gain from the services, as in they need more input. Also locally, frailty is the cause of death in about 50% of cases. And the next slide, I'll explain to you why that's important. Okay, so this slide here is looking at the Black Country and West Birmingham STP, and what it shows is that for each cause of death, so sudden death, organ failure, cancer and frailty, where they die. So if you look at cancer, which remember is only a small amount of our deaths, they have 16% of them die in the hospice. And if you compare that to frailty and organ failure, it's much, much, much higher. And what that hospice death rate signifies is really access to palliative care and care planning. So we are much, much better at identifying people with cancer as being in the last year of life and dying. We're much better at referring them on to the correct services, and therefore they get better palliative and end-of-life care. Whereas organ failure and frailty, which both make up a lot bigger proportion of our deaths, they don't get the same service. So, and there's lots of reasons for that, and Carolyn will talk a bit more about that, but it's about kind of predictability of dying and ease of kind of picking them up, and probably volume as well. That's just something to bear in mind, that we need to focus in a bit on improving identification for organ failures and frailty and dementia. So I just wanted to tell you a little bit, quite briefly, about the QI that we're doing in Sandwell at the moment. So we want to deliver the 6 ambitions from the policy to realise the vision and the goals of the Black Country strategy. And we have 3 work streams that are going at the moment. So the first one is community engagement and bereavement, which is about improving death literacy, improving bereavement services, and encouraging the community to care. The education arm is, so at the moment we have a programme in place supporting district nurse education, but actually this is just the first strand of what will be a much broader education project. So we want to be educating all the groups in the community that are involved in caring for people at the end of their lives. And this webinar is part of the primary care work stream, and that's very much to support community services and general practice to provide better and more proactive care in the last year of life. And a lot of that is about identifying patients and kind of maintaining a good end-of-life care list. Because to give any kind of proactive care, the first step is to identify the patients. Without that, they can't access anything. So I'm not going to talk in detail about the tools that we can use, because Carolyn's going to talk in more depth about that. But just to mention that there are lots of tools out there that can support identification and proactive care planning for people in the last year of life. NICE supports the gold standards framework mechanism. We have in SWB, we use the SPICT tool, the supportive and palliative care indicator tool. And the daffodil standards were developed by Marie Curie and the Royal College of General Practitioners together. And it doesn't matter which you use, they all aim to do the same thing, and they encompass a lot of the same principles. So they have some kind of support tools for identification of patients, usually with general indicators of decline and specific disease indicators of decline. And then once you've identified your patients, how you go about proactive care planning and monitoring from then on. It doesn't matter which of these tools that you use, they all do the same thing. So I'm now going to hand over to Dr. Berry, who's she will introduce herself.
Thanks, Becky. I'm just going to adjust this because we're slightly different heights. So we're very different heights, actually. So yeah, my name's Carolyn Berry. Just a little bit about myself to explain what qualifies me for being here. I'm a GP. I work in Your Health Partnership, which is a group of practices within Sandwell. We're integrated with Sandwell and West Birmingham Trust, and we've got a list size of around 50,000 patients. I also work as a palliative care doctor with the Connected Palliative Care Hub within Sandwell. And over the last 3 years, I've been doing a Master's in Palliative Care through Cardiff University. And in this last year, as part of that, I've been doing a quality improvement project with the goal of improving palliative care within your health partnership. Now, we're still a long way off, but the main outcome of the quality improvement project that I've done in the last 12 years is seeing an increase in size of our register, which has almost doubled from the start of the project to the end of the project. So whilst we're not hitting our 1%, we have seen an improvement in identification. And so I'm going to go a little bit through how we did that, some tools that we did. I'll discuss briefly the GSF and SPICT that Becky has mentioned, and some practical ideas about it. But first of all, I just want to give you the definition, the World Health Organization's definition of palliative care. I'm just going to read it out. Palliative care is an approach that improves the quality of life of patients, adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So I've highlighted 3 key points that I just wanted to bring out of that definition, which is why it's so important for us to identify our patients. Obviously, we want to improve the quality of life for these patients, and that's what the goal is. I've highlighted their life-threatening illness, and we'll see later, obviously as GPs and other healthcare professionals, I think cancer traditionally has been where we offer much better palliative care, and Becky's already shown that in that graph that she showed, but it's all about all life-threatening illness, so we need to be picking up patients without cancer that have chronic illness. And obviously, to prevent and relieve suffering, part of that is early identification, and that's really the focus of today's webinar. So why do we need to identify patients? So obviously, to improve care and quality of life, that stands to reason. There is some evidence actually that good quality palliative care can even improve life expectancy, which is unexpected, but nonetheless there is some evidence for it. By identifying patients, advanced care planning can be carried out, and this can help with avoiding unnecessary hospital admissions. Obviously also reducing unnecessary workload for practices, because if you're able to talk to patients about what they do and don't want, many will communicate that they don't want certain investigations and they don't want certain things done, and that will reduce workload for practices. We would see reduced emergency calls with planned care, so if patients are prepared for things, they know what to expect, they have things like anticipatory medications in place, then we're going to see less emergency call-outs. And there is actually evidence of a net cost reduction to practices by offering better advanced care planning. And obviously within Sandwell, by identifying patients, we can also obtain support from the Palliative Care Hub, who offer a really great service to our patients and do offer 24/7 support in conjunction and working with general practices. So, as Becky said, approximately 1% of the population will die in the year of a GP list, and this image is actually taken from the GSF guidance. So the suggestion is for an average GP, they will have approximately 20 deaths per year, and of those, only 1 or 2 will be sudden and unexpected, which means the rest are probably predictable. There's evidence that GPs do quite well for adding cancer patients to their registers and identifying those for palliative care. And if you look at the right-hand side of this image and the graph, the blue graph, you can see why that is really. And it's all about what's called the trajectory of decline. So patients with cancer will often be functioning normal, living well and healthy lives until their diagnosis. And then you see a very rapid and predictable decline until their death. And that is why we do so much better in identifying patients with cancer. So whilst cancer has traditionally been the focus of palliative care, as we alluded to in that definition for the World Health Organization, we should be offering care for chronic illness, and chronic illness is massively on the rise. We're seeing huge increases in deaths from chronic heart disease, chronic respiratory disease, and obviously frailty and dementia. Within the UK, it's now the leading cause of death. Dementia is the leading cause of death, and numbers are expected to quadruple by 2040. So it's a massive amount of our workload and of our patients. Prognostication, though, is much more difficult in these patients, and you can see why. So the graph at the bottom is patients with dementia. Obviously, they're going to start at a lower level of function because they're often more elderly when they're diagnosed. But you see a much slower and much more gradual decline with a long, much more drawn-out process. And obviously that makes it much more difficult to know when is that final 12 months, when is that last year, when do we need to get the care in place. But obviously there's nothing stopping us starting those conversations much earlier with these patients, not least because by the time they're in their last year of life, they will have lost capacity to actually communicate their wishes as well. And then similarly, chronic disease, heart failure, respiratory disease typically follows quite an up and down curve, which you're seeing in the middle there. So you see an overall decline over their life, but you see huge dips in function with exacerbations. And therefore it can be difficult to predict when that last dip is, as it were. I can think of a typical patient with COPD who was told more than 2 years before he actually finally passed away that he was in his last weeks of life, and conversations about resuscitation happened, and then he bounced straight back up again. And whilst yes, he did decline and he has now passed away, he found it quite difficult therefore to have conversations about resuscitation and about palliative care because of the prediction. So that makes those conversations difficult, and it does make the prediction difficult. But there are some tools to try and support us with this, which I'm now going to talk about. And we've mentioned them already, but the GSF is one that we use within YHP. It's very, very similar to the SPIT tool, and I'm actually going to show you both on the screen. But this is taken from the gold standards framework. The gold standard framework does ask the surprise question at the beginning. That's where it's different to the others. And the question is, would you be surprised if the patient was to die in the next months, weeks or days? So would you be surprised if the patient was to die over the next 12 months? Because if not, obviously, we should be thinking about palliative care. I do think people often struggle with this question, and I've seen patients where, to me, it's fairly clear that they probably are in their last year of life, but if you ask somebody else, they're not surprised. So I would probably say use this question with caution and actually focus more on the other elements of the GSF which match with the SPICT, and that is looking at general indicators of decline and then disease-specific indicators of decline. So I'll move on to those on the next slide, but essentially there are general indicators that a patient may be deteriorating, and then there are disease-specific ones that are listed. So firstly, look at the general ones. Does the patient tick lots of those boxes? Because if they do, it's appropriate to start the process for considering palliative care. If you're not sure, or it's a maybe, then look at their disease-specific indicators, and I'll just move on to those. So I'm not going to read all of these out. You can find them by Googling the GSF, but essentially these are the general indicators of decline, and it include things such as repeated unplanned hospital admissions, decrease in functional performance status, decrease in response to treatments, and I think very significantly patient choice for no further active treatment. So sometimes patients will communicate a wish not to go to hospital, not to be investigated, and that is an indicator, again, that we should be considering palliative care. So if it's still not clear after asking those questions of a patient, then you move on to the disease-specific indicators. Now, you won't be able to read this, I don't think, unless you've got brilliant vision, but this is just to show you what it looks like. This is an A4 page, so you can print this out and stick it on your clinic walls or something to help prompt you. But this is the GSF PIG Prognostic Identification Guidance, and it's got all of the questions. So it's got the general indicators at the top, and then it's also got the disease-specific indicators. So just zooming into this one to show you, this is for COPD. So indicators might be recurrent hospital admissions, significant breathlessness, very severe FEV1, on long-term oxygen, and then other factors. And there's lists of these for each disease. And just to show you the SPIC tool, again, this comes on an A4 sheet, very nice and clear. You can print it out, you can laminate it, you can put it on your clinic room doors, walls, just to remind you and prompt you to ask the questions when you're seeing patients. So that, again, general indicators of decline and then specific ones. This is on one page. I've just separated it out for the slideshow. And this is the SPIC tool. They're very, very similar, and so, like Becky said, it doesn't really matter which one you use, but they are useful. So it's clear, therefore, that early identification is important, and using the SPIC tool or the GSF can help with that. And as I said, I've been doing this quality improvement project at YHP to try and identify patients, and I'm just going to run through some of the things that we did within YHP. As I said, we're far from there, and we've still got lots more to identify. And some of these didn't quite work as well as they could have done for us, and different things will work differently for different practices depending on how you work and who takes responsibility for these things. So these are just all ideas. The first one that we could all do, and it's quite easy, although it might give a lot of work to the palliative care hub in the initial phase, is getting a list of patients from the connected palliative care hub that's within Sandwell. I know there might be some people outside of Sandwell, so obviously in your areas maybe there's an outside agency that has a list as well. So obtaining a list from the connected palliative care hub. So when I did this, we found that there were a significant number of patients on the Sandwell Hospital register, but they were not on our practice register. And that's because referrals into the palliative care hub come from speciality doctors and from hospital admissions. And if we're not picking that up when they're coming back to us, they may be on their list but not ours. So matching those two lists up can actually help build your list quite quickly. Actually, we got a significant number on our list based on that alone. And obviously we've mentioned one of the arms of this quality improvement project is education of staff, but that is an important element, and making sure staff are aware about the tools that can be used and considering advanced care planning. So within YHP we did do some training with our GP registrars, and I did some communication with the pharmacy team and with the advanced nurse practitioner team, and just getting people thinking about this. And getting people asking the questions when they're seeing patients can really help in building the list. Care home patients is an obvious one. We know that particularly nursing homes, so not residential homes, but nursing patients will often have a life expectancy of less than a year. So by very definition, a lot of them probably should be on our palliative care registers, and we should be talking about advanced care planning with them. So starting to look at your registered patients that are at care homes and thinking about that can again help build the list, and this is where the frailty and dementia patients with frailty and dementia, would be picked up, some of these as well. Looking at diagnoses and conditions that might prompt consideration of palliative care, on your discharge summaries, on your specialist letters. So obviously one of those general indicators of decline is repeated hospital admissions. So if you're seeing a discharge summary and you realise that that patient within last month with the same, and last month with the same, and the month before with the same, it needs to prompt these conversations and these questions. And again, looking at specialist letters for diagnosis, you might get a letter from a cardiologist saying that they're on maximal tolerated therapy. Again, that's an indicator to consider it. Talking about chronic disease, thinking about your current chronic disease registers. So within practice, we've all got registers. We've got registers of patients with heart failure, patients with COPD, and many of these patients are already having an annual review, either with a nursing member or with a GP or with somebody on your team. And considering adding either the GSF or the SPICs or a question like that to your chronic disease registers, to your annual review templates, if you use them, or whatever you use to do your annual reviews, is really worthwhile, because it just asks the question. That's not to say within the annual review you're going to do the advanced care planning discussion, but it might prompt you to bring that patient back or to consider it. So we're just looking within YHP, we haven't actually done this part yet, but in adding that tool to our disease templates so that we can ask that question when the patients come in for that annual reviews. Another thing to think about is how you're actually adding patients to the register, where that register is. So when I first started, it was post-COVID, so things had got a bit put on the by the wayside, but our register was completely out of date as well. So there were patients that had died more than 12 months ago that were still on the register, and there were patients on the register that just didn't have a palliative diagnosis. Either it had been incorrectly added or something had changed. So having a process in place, whoever's responsibility that is. So we've got a template set up now on System 1, which codes the patient as palliative, and we can send a task to our admin team to add that patient to the register. And similarly, you need to think about what happens when the patient dies and who's removing them from the register as well. MDT meetings, multidisciplinary team meetings, are a big part of the GSF and the daffodil standards, and it's important to make sure that we have time to talk about those patients. So if you don't already, trying to establish multidisciplinary team meetings is helpful in not only helping with identification, because you can discuss patients where you're not sure, but also obviously when it comes to more proactive care and caring for those patients. I'm thinking about the wider MDT, so not just within the practice, but that's important, bringing in your whole practice team, but also the wider MDT. So we've had community respiratory nurses joining us, district nursing team, heart failure nurses, trying to involve and seeing how we can liaise with our community teams who often know our patients sometimes better than us, and can help in supporting with identification. And I'm going to mention this on a further slide, but there is a tool called the Early tool, which has been created to help us identify patients. I'm going to go through that shortly. It does depend on coding, and actually I did start to use it, but within YHP it didn't really help for the list that I used because of the coding. So for example, the COPD patients were coming up, and I was finding there were many young asthmatic patients. To be truthful, I didn't use it for all of the list, all of the diseases, so it may be useful, and I think lots of people do find it useful because it uses codes within our systems. So I'll talk about that shortly in a minute. This is just to show you as well that the SPICT tool is embedded. I'm talking about System 1. I'm sorry, I don't know EMIS for those of you that use EMIS, but I suspect it's probably in both. The SPICT tool can be found as an already established template on System 1, and that's just to show you where to find it. It's in Clinical Tools, Launcher, search for the SPICT, and you come up with this template called the New Palliative SPICT Support and Palliative Care. So if you haven't got the capacity or the wherewithal to create your own templates or edit your own templates, then you can use this template within your practice, and it gives you the prompts and ask the questions. I'm just going to show you it, I think, on the next slide. Yeah, so this is what comes up when you open that template, and it just asks the questions. General indicators of decline, you can check the boxes, and then the disease-specific indicators of decline. And then just to talk about the early detection tool. So as I said, this has been it's embedded into System 1 and EMIS, and it's a tool that's been developed using SNOMED codes that may indicate a patient may be in their last year of life. And it's based essentially around those SPICT and GSF questions, and it's based on those criteria. As I said, it does depend on your coding being done well and done correctly, and I didn't find it as useful as I'd hoped, but I didn't use it for all of the diseases, and it might be something for us to work on as well. But essentially you can find it. This is for System 1. Again, you would have to Google it for EMIS, but in the reporting header, clinical reporting, Midlands and Lancashire CSU, and search for the early detection tool. And this just shows you what comes up. So you can see we're getting lists of patients with cancer, with heart failure, COPD, kidney disease, and it gives you a list of patients that have those codes within their records that might be indicating that they should be being considered for advanced care planning and palliative care. So you can pull off those lists and have a look at them. So that's quite a practical way to try and identify patients. Obviously, this is based on YHP, which has a list size of 50,000 plus, so it might be quite a lot simpler for the smaller practices as well, who will have, I'm assuming, much smaller numbers there on their lists. So those are the things that we've done, and as I said to you, I'm not an expert, and we're still far from achieving the 1%, and it's not easy, and there's still challenges. The primary one remains the difficulty in prognostication. So even with the SPICT, even with the GSF, there's still patients who live longer than we expect, who follow different trajectories to what we expect, and it can be difficult. You know, that's a national issue. So we just need to keep working on it and keep trying to consider it with these patients. There also continues to be a mindset about palliative care being the end of the road and giving up on patients. And you hear phrases like, they're not palliative yet. And you hear that from patients and their carers. You hear that from clinical staff too. And I think it's a matter of reframing and explaining what palliative care really is. As we saw from the World Health Organization's definition, early identification is part of palliative care. And it's not giving up on treatment. We can continue treatments, we can continue interventions for as long as the patient wishes, but it's about how we communicate and how we sell it. So actually, the idea is quality care to help patients to live as well as possible for as long as possible. And I think if you sell it like that, often patients will go, oh, that's not what I thought. You know, people think it's the last week of life, or think of hospices and palliative care. So thinking about how you communicate to both your patients and carers and staff that you may be working with as well. And time and money is another challenge. A common comment you hear talking about palliative care, we just don't have the time to do it. And I get that. I work in general practice, as I've said. General practice is under huge strain. But there is evidence, and I've put in brackets, is this a false narrative? Because actually, putting some time and effort into this care planning can actually help save time and potentially save money, certainly for the NHS, because we're reducing unplanned hospital admissions, we're reducing emergency call-outs, we're reducing unnecessary investigations, and we're giving patients the care that they want rather than what we think they might need. So arguably, if done well, if we can find the time to do it well, if we can find the time to start having these conversations, it may actually reduce the time that we need to spend with these patients. Things to consider for the future, obviously building the register is one thing, but as we've said, identification is just the first step. And I know we've not talked about anything else, and that's probably to come, but we need to then be considering about how we're going to manage these patients, how are we actually going to offer them the care. So yes, identification will allow them to access support that they need, and just by the very fact that they're being recognised will help them access things like the palliative care hub and just an awareness of them. But how can we proactively monitor these patients? How can we offer care to these patients? Because obviously bigger list sizes does increase the workload to some degree. We need to do, as I've already said, this continued work on identification of patients with non-malignant disease. And I think another key point is obviously, given the pressures general practice is under, thinking about how can we, and I've already mentioned this, I think how can we work better with outside agencies, even non-NHS agencies or community services within the NHS. For example, within Sandwell, we've got the Dementia Care Navigation Service. They see all of our patients with dementia, they know them really well, they know their carers, and they've actually started doing some advanced care planning as part of their care. But there's no cross-communication, and so sometimes the duplication of work is there. So if we can work on ways to communicate better with these groups, it may be again that we can reduce the workload and start working together for our patients. So I'm going to pass over to Becky now, who's going to carry on, just to give an opportunity for discussion and questions, but I might just stand on the side and crouch so we're the same height.
Yeah.